So again, if we look at the individual studies, we are not comparing the details, we are not looking at the decimals here, but so I mentioned the drug approval for daratumumab and carfilzomib. So there was a paper published in 2019, the first CAR T-cell, the BB2121, the Bluebird CAR T-cell, and that is a drug that targeted BCMA. They had about a year or so of progression-free survival follow-up, but those patients were a little bit more heavily pre-treated.
Yeah, and I think that it's a really good point. You know, we only have the data we have, right? So of course we're going to look at studies between studies and see what are the differences. You know, no one wants to compare these two very exciting drugs to each other right just yet, because there's just too much exciting data coming out that's early. So in the CAR T study, the BB2121 study, the patients received a median prior of 7 lines. So it's a little bit more heavily pre-treated, and they had to have had 3 lines before going on the study. Their response rate there was over 80%, around 85%. But as you mentioned, the PFS was comparable, 11.8 months versus the 12 months we're seeing with the BCMA-ADC drug. So that's comparable. I think it's a different science that the CAR T cells are working with versus the BCMA ADCs, and I'm hoping that we can put these things together eventually to get a better PFS, whether it's going to be sequencing or combining them, but they're definitely 2 different patient populations, and I think the differences we're seeing in the data reflect that. However, the similarities in the PFS also bring to our mind that maybe that these are things that can be used for similar patient populations eventually, and it'll be a question of who is best fit for what.
So the current protocols that are in our clinics for both the CAR T cells and the antibodies, these ADCs, they exclude patients with the exposure to prior BCMA-targeted therapies. So you cannot receive CAR T cell and go on the antibody, or you cannot receive antibody and go to CAR T cell. Do you think once these drugs are FDA approved that clinicians will use them after each other?
Yeah, actually I do, because my personal opinion, and we have some hints of this, although this has not been completely proven, is that having a progression after a BCMA CAR T cell does not necessarily mean that you lost BCMA. It's that whatever cell was in there isn't working anymore. And so as long as you have that protein still on the surface of the target tumor cell, then it's worth looking at another modality to target it. And I would advocate for even having a cohort of patients in a clinical trial that are BCMA exposed, and some trials are doing this now, and then having those patients go on to get either the bispecific therapy or the BCMA ADC therapy. And I think it makes sense if you can prove whatever means that we have, IHC or RNA or proteomics, that they still have BCMA, then it's worth giving them another shot. And there was a ASCO abstract presented this past year where patients had received a BCMA CAR therapy that was humanized after, and 4 of those patients in the 10 that were presented had previously received a BCMA CAR T therapy that was murine. And actually all 4 of those patients did respond to this new CAR T. So it lends the idea that maybe we do have an opportunity to retreat people, but with different BCMA-directed therapies.
And this concept is not really new to think about retreatment. If we think about the currently FDA-approved classes of drugs we have, the first so-called novel class of drugs was bortezomib,
right,
the proteasome inhibitor, and there are now 3 FDA-approved proteasome inhibitors, and they all go after the same 20S subunit.
Right.
So we have bortezomib, we have carfilzomib, and we have ixazomib.
Right.
And there are data that even led to the registration that you can use them after each other. And we know that in clinical practice.
Right.
And the same is true also for the IMiDs.
Exactly.
Again, also FDA-approved. You can use Pomalyst after you have used, or pomalidomide after you have used lenalidomide.
Right.
And
Which we do.
Yeah, which we do, and
yeah,
that was also how it led to its approval.
Right.
So we know that you can recycle different drugs. You can go back to the same drug even if you give a little bit of a break, probably. So,
yeah, and these are different mechanisms of action. It may be same target, but different mechanism of action. So I think it's worth sequencing them, at least trying it, because these patients do need other options after the CAR T failure.